A lung abscess is a localized collection of pus within destroyed lung tissue, producing a thick-walled cavity caused by severe microbial infection and necrosis. The commonest cause of lung abscess is aspiration of oropharyngeal secretions containing anaerobic bacteria, especially in patients with impaired consciousness. Lung abscess may also result from bronchial obstruction, necrotizing pneumonia, septic emboli, fungal infections, trauma, or severe immunosuppression. Anaerobic oral bacteria are the predominant pathogens, although Staphylococcus aureus, Klebsiella, Pseudomonas, and Streptococci may also cause lung abscesses. Following bacterial invasion, alveolar macrophages activate inflammatory cytokines that recruit neutrophils to eliminate invading pathogens. Persistent infection causes liquefactive necrosis, destroying lung tissue and creating an enlarging focus of suppuration. As necrotic tissue liquefies, a thick-walled cavity forms containing pus and an air fluid level once it communicates with bronchial tree. Patients typically develop persistent fever, productive foul-smelling sputum, chest pain, weight loss, and prolonged cough.
Chest X-ray is the initial imaging investigation, typically a thick-walled cavitary lesion with a characteristic air fluid level surrounded by pulmonary consolidation.
Lung ultrasound can accurately detect peripheral lung abscesses, demonstrating a thick-walled hypoechoic cavity containing internal debris and purulent fluid. Chest CT accurately demonstrates a thick-walled cavitary lesion with an air fluid level and surrounding inflammatory consolidation. Bronchoscopy excludes obstruction and obtains respiratory samples for microbiological identification and antibiotic sensitivity testing.
Prolonged intravenous followed by oral antibiotics remain the cornerstone of lung abscess treatment.
Treatment of secondary lung abscess includes relieve bronchial obstruction, administer antibiotics or antifungals, eradicate septic embolic sources, store immunity, and when medical therapy fails, image-guided percutaneous drainage effectively evacuates the abscess while preserving healthy lung tissue. Lobectomy may become necessary when irreversible lung destruction, uncontrolled infection, or malignancy prevents recovery.
Future treatment combines AI with rapid molecular diagnostics, targeted nanomedicine, and regenerative medicine to eradicate infection while restoring healthy lung tissue.
While mortality was as shy as 70% in the pre-antibiotic era, modern approaches have significantly improved outcomes, now ranging between 5 and 15%, thanks to early CT diagnostics, antibiotics, and interventional procedures. A lung abscess is a localized area of suppurative necrosis. It is characterized as a thick-walled cavity containing a purulent core surrounded by inflamed lung parenchyma. Lung abscesses are categorized as primary or secondary. Primary abscesses occur in previously healthy lungs, often due to aspiration in individuals with risk factors. Secondary abscesses arise from underlying conditions like structural lung disease, immunosuppression, or obstruction from malignancies. Microbiologically, anaerobes are the most common cause, often linked to aspirated oral flora. Aerobic organisms are also significant, particularly in hospital-acquired cases or structural lung disease. Opportunistic pathogens are more frequently seen in immunocompromised patients. Gravity plays a key role in the location of aspiration-related abscesses. Because the right main bronchus is wider, shorter, and more vertical, aspirated material often gravitates toward the posterior upper lobe or the superior segment of the right lower lobe in patients in a supine position. The pathogenesis follows a cascade, starting with aspiration and colonization, followed by a host inflammatory response. This leads to tissue destruction and liquefactive necrosis, which eventually forms a cavity. This cavity may then communicate with the bronchus, potentially leading to healing or chronicity. The appearance of an air fluid level on imaging occurs in stages. Initially, the cavity is closed. Upon rupturing into a bronchus, the necrotic material is partially drained, and air fills the upper portion of the cavity, creating the classic horizontal interface seen on an upright chest X-ray. Patients often present with a productive cough, fever, chest pain, and fatigue. Complications can be severe, ranging from empyema and bronchopleural fistula to massive hemoptysis, respiratory failure, and in some cases brain abscess or chronic fibrosis. Diagnostic evaluation involves assessing systemic markers and microbiological sampling. Modern techniques, including PCR and next-generation sequencing, are increasingly used alongside traditional cultures to provide precise identification of the causative organisms. While a chest X-ray serves as an initial screen, a CT scan of the chest is the gold standard. It provides detailed information on cavity walls and location and helps distinguish a lung abscess from other conditions like empyema or underlying malignancies. The differential diagnosis for cavitary lesions includes tuberculosis, necrotizing carcinoma, and infected bullae. Each has distinct clinical, radiological, and microbiological features that clinicians must evaluate. Treatment follows an escalation pyramid. Medical therapy with broad-spectrum antibiotics is the first line of defense. If patients fail to improve, interventional options like bronchoscopy or percutaneous drainage may be required. Surgical resection is reserved as a final, absolute last resort. Surgical management is indicated for persistent sepsis, massive hemoptysis, or destroyed lung tissue. Procedures range from minimally invasive techniques like VATS and RATS to resections such as lobectomy or, rarely, pneumonectomy. We are seeing a paradigm shift toward precision medicine. This includes rapid molecular diagnostics, targeted drug delivery, and the use of image-guided navigation for interventions, all aimed at reducing morbidity and improving patient outcomes. In summary, remember that aspiration remains the primary cause of lung abscesses. Management relies on prolonged, culture-directed antibiotics, with surgery reserved for complications. Prevention through good oral hygiene and aspiration precautions is essential.
Prior to the widespread availability of broad-spectrum antibiotics, a lung abscess carried a 70% mortality rate. Today, with the precise application of modern interventions, that death rate has dropped to between 5 and 15%. Medically, a lung abscess is defined as a localized area of suppurative necrosis within the lung parenchyma. It presents as a thick-walled cavity filled with pus, surrounded entirely by inflamed lung tissue. This massive improvement in patient survival is the direct result of understanding the mechanical and biological evolution of this specific necrotic cavity. A lung abscess presents a biological paradox. Microscopic bacteria carve out a macroscopic void in normally healthy, highly resilient, spongy tissue. This destruction happens through a highly predictable 7-stage pathophysiological sequence. It progresses linearly from a gravity-driven aspiration event into host-mediated necrosis, and finally to structural rupture. Tracing the mechanics of these 7 stages provides the exact logic for why prolonged medical therapy is the cornerstone of management, and why aggressive surgery is deliberately avoided. The sequence begins with microaspiration. When normal airway defenses are bypassed due to altered consciousness from alcohol, general anesthesia, seizures, or physical dysphagia, oral secretions slip past the vocal cords. Once past the larynx, the path is dictated purely by gravity. Because the right mainstem bronchus is wider and more vertical, fluid drops directly into it, pooling in dependent pockets, typically the right lower lobe or the posterior upper lobe. This fluid carries a heavy polymicrobial payload of oral anaerobes, primarily species like Bacteroides, Fusobacterium, and Peptostreptococcus. Sequestered deep in the alveolar spaces, These anaerobic bacteria rapidly multiply and release local toxins into the surrounding tissue. The infection is a crime of opportunity. A brief mechanical failure of the gag reflex plants a toxic seed in the most vulnerable, gravity-dependent pocket of the lung. The lung's resident first responders, alveolar macrophages, detect this rapid proliferation of anaerobic bacteria. They immediately trigger a chemical alarm system, releasing potent inflammatory cytokines, specifically interleukin-1, IL-6, IL-8, and tumor necrosis factor alpha. This steep cytokine gradient triggers a massive systemic recruitment of neutrophils, which swarm out of the bloodstream and into the infected alveolar space. Complement proteins activate, further amplifying this aggressive local inflammatory cascade. This immense immune deployment is designed to sterilize the lung, but the volume and aggressive behavior of these inflammatory cells render the local microenvironment a destructive war zone. The swarming neutrophils unleash a barrage of proteolytic enzymes and reactive oxygen species to kill the bacteria. This leads to liquefactive necrosis. Host-derived enzymes and microvascular thrombosis cause the lung parenchyma to dissolve, accumulating dead cells and bacteria as thick yellow-green pus. To contain the infection, fibroblasts migrate to the perimeter, constructing a dense, fibrous wall. This quarantines the necrotic core into a cavity 2 to 6 centimeters wide. By attempting to quarantine the infection, the body creates a heavily fortified avascular bunker that physically shields the surviving bacteria trapped inside. Inside that bunker, pus continues to accumulate, driving up internal pressure within the fibrous wall. Eventually, the necrotic cavity erodes into an adjacent communicating bronchus. For the patient, this internal breach triggers their primary clinical symptom, a sudden, severe bout of coughing that produces copious amounts of foul-smelling sputum. As the pus partially drains out through the airway, atmospheric air rushes in to fill the newly created void. Gravity forces the heavy pus to the cavity's bottom, while air sits on top. Because liquids settle flat, this creates a perfectly straight horizontal boundary. This is exactly what appears on a CT scan as the classic air fluid level. This radiological sign provides a direct visual record of the aftermath of a ruptured necrotic battlefield. To manage this damage, contrast-enhanced CT serves as the diagnostic gold standard. Clinicians use it to precisely map the cavity wall thickness, pinpoint the exact location, and check for any endobronchial obstruction. Crucially, high-resolution scans allow physicians to differentiate a primary infectious abscess from a cavitating malignancy. While imaging outlines the structure, microbiology is advancing how we identify the contents. Metagenomic next-generation sequencing and rapid molecular panels can identify specific pathogen RNA within hours, bypassing the slow 48-hour process of traditional anaerobic cultures. Acquiring precise structural data via CT and rapid pathogen identification via sequencing provides clinicians with the exact evidence required to trust a non-surgical approach. The cornerstone of that non-surgical approach is medical therapy, an aggressive course of IV to oral broad-spectrum antibiotics, typically utilizing beta-lactam beta-lactamase inhibitors, or carbapenems. But the duration of this therapy is notably long, stretching to 4, 8, or even 12 weeks. This chart shows the pharmacokinetic challenge of the abscess architecture. The dense fibrous wall constructed by the host is highly avascular. Because the blood supply is cut off, blood-borne antibiotics penetrate the cavity interior at a severely restricted rate. Medical management is a game of extreme patience. The clinician must maintain systemic antibiotic pressure long enough for the thick-walled cavity to slowly heal, drain, and eventually collapse into a harmless scar. Mechanical intervention is only considered when strict failure conditions are met. If a patient fails to improve on targeted antibiotics, or if the abscess is massively oversized, exceeding 6 centimeters, physicians escalate to image-guided percutaneous drainage. Actual thoracic surgery to resect the infected lung, a method historically relied upon, is today strictly an absolute last resort. Resection is reserved only for catastrophic complications: massive hemoptysis, a bronchopleural fistula, rupture into the pleural space causing empyema, or when the cavity is confirmed to harbor an underlying malignancy. Successful management of a lung abscess requires respecting the physical architecture of liquefactive necrosis. Physicians rely on time and targeted pharmacology to slowly penetrate the cavity wall, keeping the scalpel sheathed until the lung's structural integrity entirely collapses.